And as usual, we'll begin with concept review and then have some discussion and skill building time. So as Diane mentioned, here we are in June, upcoming webinar dates and topics. If you are hoping that we would cover something in the webinar series that you don't see here, feel free to send in requests for topics that you would like to cover or skills you want to practice. Definitely can make modifications and adapt to your preferences and priorities. So please remember that this is not meant to just be a one-way dialogue, and I hope that you will continue to do the great job of participating that this group has always done. So this is just a little word cloud with some MI words. And I created this a while ago, and I actually don't remember what document it came from, but I thought it was kind of cool and inspiring image. So if it's something that you enjoy having posted around your workspace or whatever to kind of keep you in the zone, that's something Diane can share the slides with you all, and feel free to print it out. Okay, so the 4 processes. Here we are kind of reorienting ourselves to the framework of a motivational interviewing conversation over time. So this is a set of guiding principles in a way in terms of how we would want to facilitate the unfolding of a conversation using motivational interviewing, knowing that we may or may not conduct all of these processes within the span of one conversation. So today we're talking about the skill of agenda setting, which fits within the process of focusing. So we're talking about not just creating focus, but then sustaining it. And we know that conversation can come from the setting. So sometimes we work in environments where we have very, very specific scope or area of focus. And for example, if you work in a diabetes specialty practice, or an endocrinology group where that is their focus, then that is what you're going to talk to patients about. Sometimes the focus can come from the patient and their priorities, and sometimes the focus can come from the practitioner. Now, in MI, what we're trying to do is find a way to have the focus be jointly established by the setting or clinician and by the patient, so that there's a sense of collaboration and partnership in creating focus in the same way that we take that approach as kind of an overarching clinical style, that we're not overly directive, we're not overly following, we're coming down in the center here in terms of using a guiding style. Okay, so part of this is about going from asking the question, what's the matter with you, and thinking in terms of a problem list and a set of diagnostic codes and a prescription pad, etc., to thinking in terms of what matters to you. And I'm curious from you guys what your perspective is on the question on the top of this slide. What are the benefits of changing the underlying question that we're asking people in medical? If we're changing the underlying question from what's the matter with you to what matters to you, what are the upsides of doing that?
Definitely client-centered.
Mm-hmm. Yeah. Yeah, so it's kind of maybe the only way we can really be client-centered is by finding out what matters to the individual.
This is Stephanie from All Care. How are you?
Good, thank you.
Good. When somebody asks me this question personally, when they say, "Well, what's the matter with you?" No matter how you say it, it seems like there's something wrong with me. Like there is something terribly wrong with me. So when somebody says, "What matters to you about your health?" and think the way that you restart, it's kind of like the same question, but it's a different angle, and then it's how you treat people the way you want to be treated, type of thing. I really like how it changed that question.
hmm So for you, the "what's the matter with you" question kind of feels like inherently loaded. Like there's almost no way to
Yeah.
ask it without it sounding a little bit judgmental, or that there's an
Yeah.
expectation that there's kind of a problem, versus what
hmm
matters to get at health priorities of all kinds.
Absolutely.
Yeah, great. Thanks for sharing that. Other
hmm
thoughts on how it's helpful for us to be changing the underlying question?
Well, obviously, this is Jane in North Central. Number one, it is trauma informed, recognizing that there may be issues behind what's bringing them to you versus what you think they need.
Mm-hmm.
And when we ask what's the matter with you, we're going to assume they're going to say, I have a rash or I have a headache or whatever I have, then I'm going to fix it for you, which may
Right,
not be what the issue is at all.
right, right. So if we're trying to conduct care that's trauma informed and activating for our patients, the only way we can do that is to find out what their priorities are and what is at the top of their mind in terms of their past experiences and their expectations out of this healthcare visit. Because I think, sometimes when we ask someone what matters to you, what we're going to hear about is the acute health problem that we would think would come up if we asked the question, what's the matter with you? Like sometimes it is the rash. Sometimes it is what matters. But not always. This is a way of not making that assumption. We can find out really what's going on for someone. And, if the big thing that they want is the acute medical issue that we would have maybe identified with the first question, great. And we also have opened the conversation in such a way that we can find out what else might be going on. I'm curious what people think about, like, in the context of trying to move into a medical home care model and be providing proactive, population-based healthcare versus reactive, episodic healthcare. How is this change to the underlying question? How does it fit in with that transition?
This is Jane at North Central, and
hmm
what I see is that historically Western medicine's model of here's a problem, I'll write you a prescription or tell you how to fix the problem, in the context of the four walls of my office, doesn't necessarily meet perhaps the need for a more holistic approach of support or resources outside of the four walls. And so I think what I've seen is the healthcare medical home has had to really stop and go, okay, what else do we need? How else can we be integrating and more inclusive of other resources besides the prescription pad and the handout sheet?
Mm-hmm. Yeah. So if we're going to accomplish this goal of trying to move beyond the prescription pad and the pamphlet and the old school way of providing care and be providing proactive, preventive care, we kind of have to change the question and to not just ask what's the matter with you, what did you come in for today, but to find out what matters to you in terms of health priorities. And so it's a way of not only being more patient-centered, as you guys have described, but also it will support the.
Is it bothering the fact that I have the speaker on too?
No. So I think Angie, is it Angie? It looks like you are not muted. Angie, are you hearing me?
Yes, I can hear you.
Okay, I think we're getting some background noise. If you wouldn't mind muting your line when you're not talking, that would be great. Thanks. Okay, changing the question. It's a way of supporting patient-centered care and of supporting healthcare transformation, basically, to go from being reactive, being episodic and acute, to helping people think about their health goals in the long term and to help them move forward. Okay, so let's talk about how focusing as a process connects to motivational interviewing spirit. So these are a couple of different aspects of focusing that are from the third edition of the Motivational Interviewing book that can help us describe what focusing looks like in terms of MI. So the first one is about tolerating uncertainty. So this is about letting the focus be unclear at first and not jumping in to try to nail it down and to give into that writing reflex of, you know, we don't have very much time and we got to get something done, and, you know, this is what we're going to talk about. And that doesn't mean that we don't facilitate a focusing process, but it's about letting there be some open space in there for sharing control. So if we're going to tolerate uncertainty, we have to do that in the context of sharing control so that we know that together we will find clarity and we will find focus. And it may look a little bit different than we expected. It may take a little bit longer, but if we end up finding a focus that actually is relevant and important to the patient, we will likely get more traction in the long term. So we're kind of investing in the long-term productivity of our conversation by finding an appropriate focus on the front end. So this is also an opportunity to be listening for change talk, to be listening for patient strengths and stories of survival or resilience and values, aspirations for change. So this is a time as you're exploring to be always mining and always keeping your ears open for fodder for your future affirmations and reflections and discussions about change. Oops. Okay, so this is a quote from the MI3 book that is kind of like one of the big ideas behind motivational interviewing and why motivational interviewing is effective in working with people who are even what we would call in like pre-contemplation mode in terms of stages of change, people who aren't really thinking about making change yet, or people who are just starting to think about making change, where we say in MI, using our skills, no matter how small that glimmer of change talk may be, we can find a way to give it air, and we can find a way to try to create some sparks and then to fan those flames so that we can try to get something lit and create some fuel for change. So we're always, no matter where we are in a conversation using MI, looking for the sparks and the glimmers of change talk. Okay, so if we come back to this notion of an agenda, which is at the heart of focusing as a process, creating an agenda, we have a couple of different meanings of this word that come up in the dictionary. So one is a list or outline of things to be considered or done, which on the surface level is what kind of agenda we're creating as we conduct motivational interviewing conversations. But then we also have the meaning of the word agenda that's really more about the underlying stuff. So when we talk about what agenda someone comes to a meeting with, we know that there's like the obvious thing we're going to talk about, and then there's the thing that they really care about that they're trying to figure out how to slip in, or that they can't get off their mind or whatever. So I'm curious, when you think about some of your typical patients, what's on their agenda? So maybe if someone could talk about a typical patient who comes to mind, maybe starting by describing what would we kind of traditionally or classically think of as their agenda in a healthcare appointment. What are the medical issues that we might be discussing? And then let's try to dig a little bit and think about what else is on their agenda. What is the underlying stuff that is going to have a great bearing on what happens in the appointment, as well as, of course, when we're talking about behavior change, what happens after the appointment. So is anyone willing to share a story? It could be a single patient. It could be kind of a conglomeration of a bunch of patients that just looks kind of like the typical person from your setting. Okay, so I got a comment on the chat from Julie Flint, who says, I currently have a patient whose agenda item every time is to get a referral to the Mayo Clinic or to have a surgery referral. Okay, so Julie, can you tell us a little bit more? And I don't know whether you can either type it in and I can read it, or if you can unmute yourself and talk with the group. Can you tell us a little bit more about what else is on this patient's agenda? So this is kind of like their top level medical agenda. And I wonder if you could give us some more information about, maybe what their story is in terms of why that's their medical agenda, and then what else is actually on this person's agenda that's contributing to their focus. Because clearly that's the patient focus, and it sounds like maybe or maybe not that's a reasonable goal for that patient.
So can you guys hear me?
Yes, we can hear you.
Okay. Trying to type and not talk. So this patient is somewhat new to our clinic and new to me, but is probably like the most profound example of complex trauma, and his presentation in the room is pretty overpowering. So I definitely have to approach him every single time, every moment I'm with him, with like trauma-informed approach. But I guess, so I was replying to your answer in that sense because I realized that there are a lot of other things going on, but his agenda, as if I were to really truly reflect back to him, is that he is uncomfortable in his body, and he believes that the answer is surgery because he knows his body best. Mm-hmm. It's kind of how I would reflect back the agenda that I'm very clearly hearing from him. So interventions, like kind of dramatic interventions, are always his agenda, to kind of try to arm wrestle me or his provider in making the referral for.
So it sounds like if we think about kind of what is underlying that, so maybe one of his hopes would be to feel less distress.
Yeah.
Sounds like someone who's he's suffering, he's uncomfortable.
Yeah, I think,
to feel distress. Mm-hmm. What else do you think is kind of going on for him? Hoping
what do you mean?
Well, another thing that stands out to me is maybe he's hoping to have some control over his body, or some experiences in his life. It sounds like perhaps there's been some really tough times in his life where he did not have control, and he survived some difficult circumstances. And maybe this is a way that he's hoping to have that experience of control.
Oh, yes, very much. I mean, everything in the room is about him controlling the situation. So, yeah, control is definitely, which, makes sense coming from the trauma.
Right. So some of his fears perhaps would be if he has perhaps a fear of like letting his guard down, and of what might happen. It sounds like maybe the issue of control in the exam room, like a fear of like, if I give an inch, they'll take a mile.
I think it's more that fear. he has to be in control of his body at all times, and he's not in control. I mean, he really truly is spiraling all over the place. He thinks a million miles an hour, and you can acknowledge that to him, and he'll absolutely validate that that's what's going on. So it's this weird dance between I'm in control and I have to be in control. I can't imagine a world in which I'm not in control of my body, but at the same time is saying, you know, I'm hoping for escaping this pain. I'm not in my body. This, you know, so he's doing this dance between like two different experiences. And so if you don't, it's hard to make a medical plan around addressing some of this.
Right. Yeah, it sounds like a complicated case, because I would bet, let's think about other things that might be going on for this person. I mean, please do correct me if I'm wrong, but I would imagine there is some comorbid mental health diagnoses that might be appropriate.
My nurse gut stomach feeling is that there's some borderline behaviors, but they're he, you know, in the remote past is referred to being diagnosed as bipolar, but that he's not. He's not currently. He's seeing a counselor who specializes in trauma, so he has an established counselor for trauma, but no DSM diagnosis at this point.
Okay, so even if he's
not willing to engage in that either. Well, I don't know if he's not willing, but we've not crossed that, you know.
Right. Okay, so at the very least, he has some coping strategies that may serve him in some ways, but be challenging in others. And I wonder about his social context. Like, can you tell us a little bit about his life in terms of, does he have stable housing? Does he have a job? Does he have a social support network?
Yeah, so he doesn't have a job. He has stable housing. He's got like extenuated family members that bring him to an appointment, like the parents of a sister-in-law, which is kind of odd to me. I know that he has an ex-wife and he has had a child, but my impression is that he is pretty isolated because of some of these borderline behaviors that burn bridges pretty easily. So he has some support systems, and he's got a caregiver at this point that we've gotten into the home to help with things like his showers and his laundry, but pretty limited.
Yeah. Okay. So some of what might also be going on is a desire to connect with people, a fear around doing that, fear of isolation, maybe some fear or anxiety about getting all of his basic needs met. If he needs help with that kind of thing, maybe there's probably some fear, maybe needing help, fear and lack of trust around letting somebody into his home to do all of those things. So this is a great example of someone who has a medical agenda, and then there's all of this other stuff that affects how the conversations go with him and what to focus on. Okay, so thanks for sharing that story. Let's keep going a little bit, and we'll maybe see if we can bring some other cases into our discussion. Okay, so one way that we can approach, this is an example from an Oregon Community Health Center that came to me a couple of years ago, and I don't know if this clinic is still doing this or not, but for patients who are coming in for a chronic disease visit, while they're waiting to get called back into the exam room, they answer these two questions on a piece of paper. So what's important and meaningful in your life, and what small step would you consider committing to today to move closer to what is important and meaningful in your life? So we can think about, well, how can we change our workflows? How can we change our clinic processes so that we can initiate a different kind of conversation with people? If we really want to be asking that question, what matters to you, instead of what's the matter with you, we have to think about how can we ask in some different ways. So I'm curious whether any other clinics who are on the line today have tried anything like this, and have any stories to share, perhaps about how you have a different kind of conversation with your patients. How do you find out what is important and meaningful to people? And if no one's currently doing it, then I would encourage you to think about whether there is a way you could do something like what this clinic was doing, and maybe see how it goes. Even if you did it as a PDSA, just try it out and figure out how to respond. Maybe even just doing it with 5 patients a day or whatever, and then figuring out how to have a follow-up conversation with them about it, and then letting us know how it goes would be pretty cool. Any stories to share before we move on?
This is Megan. I work with Visiting Health. I think one way I try to use this, I don't use exact questions, but I get an order from the doctor saying they need to move to an assisted living, and the patient doesn't want to move. But figuring out what's important for them to stay in their home and what we can do to get them to stay in their home and find that value in what's important to them, and trying to move forward with that, even if it's not necessarily what the physician wants.
Yeah. So really, that seems particularly important because it is in the context of such a big life decision kind of thing. Yeah, that's great. Okay, so let's think about agenda mapping in a more conceptual way. So creating an agenda in the context of a motivational interviewing conversation, and I would say really probably in the context of any medical interaction, is like examining a map before you set out on a journey. So you all have a very limited amount of time to interact with your patients, and it makes good sense to plan out the use of your time before you use it. In the same way that before you set out on a journey, you would try to figure out where are we going and how are we going to get there. So you also then, if we're thinking about focusing in terms of both setting and maintaining a clear direction, then we can also, if we have an agenda, if we have a map, then we can come back and consult it along the way. So some of the elements of agenda mapping from the standpoint of motivational interviewing are structuring, considering options, and zooming in. And we'll just talk about each of those things briefly. So one of the things to keep in mind as a practitioner of motivational interviewing is that you are bringing a particular set of skills and expertise to the conversation as a partner in the change process. Now, you're not meant to bring, of course, motivation or all the ideas about change. All that stuff comes from the patient. But one of the things that you do bring as a partner is the facilitation skills and the structure for the conversation and the ability to guide and move that conversation along. So while you're not solely creating the focus, you are creating the structure from which the focus can emerge. So one way to do that is to be very explicit about creating that structure, be explicit about the agenda setting process. And you can use hypothetical language to indicate that you're sharing control, that you're open and interested in the patient's input. You can also use we language to talk about what we are going to do in our time together today. And we can frame it in terms of also kind of asking permission. Can we take stock for a few minutes about what we might discuss today before we dive in? And you can even be very transparent about why you're doing that in terms of saying, we only have X number of minutes together and I want to make sure that we use our time effectively. So let's talk about how we're going to do it, what we're going to do in the time we have together before we dig in. So another way that you can share control and create structure, if you have some kind of assessment or questionnaire that you have to conduct, which I know many people do in different roles, you can tell the patient that and to say we could start with that, or we can leave time at the end to make sure we get to it. What would you prefer to do? Would you prefer to get it out of the way, or would you rather we have a more open-ended conversation and then we leave 5 minutes at the end to go through the questionnaire? Something like that, so that you are, again, sharing control with the patient about how the conversation is structured. So any questions or comments about this notion of structuring and transparency in structuring before we move on? Okay, so then once we have indicated that what we're going to do is create an agenda map together, then we want to consider the options. So this is about tolerating uncertainty. So knowing that we may or may not know right out of the gate what the topic of conversation ought to be, and we want to create some space for people to think about it and to consider what's most important to them, to maybe have a moment of brainstorming, to be listening for things to affirm, to be offering autonomy support, which might help both you and the patient tolerate the uncertainty of the moment by reminding everyone that it's really up to the patient what matters most to them. You could use a bubble diagram like you see here on this slide, and you can create different ones for different conditions or topics if that seems helpful. A lot of things, of course, are relevant across different conditions. Like in this slide, we have some really common health promotion conversations that we might have with people around behavior change in terms of not smoking, stress management, eating healthy, taking meds as prescribed, getting exercise, etc. And then we also use the blank bubbles to say, what else? What's missing here? And we can do this verbally as well in terms of offering a menu of options to say, here are some of the things we could talk about today, and I'm curious what you think, whether any of those sound like a priority to you, whether there's anything else that you might want to put on the table for us to discuss. And again, we use hypothetical language and reflective listening to try to let the patient know that we are sharing control with them and trying to really listen for what matters most to them. Now, this doesn't mean that we don't include our own opinion and our own sense of what we should talk about, but we do it in the context of partnership by supporting autonomy in terms of asking permission and emphasizing patient control. So, for example, this could sound like, from my perspective as a diabetes educator, I think that talking about exercise habits would be a really helpful thing for us to do today. But ultimately, it's up to you what your highest priorities are, and I'd like to hear what you want to start with. Or if you feel that you have something you need to talk about and you really need to talk about it no matter what the patient thinks in terms of priorities, you could say, it's my job to talk to you about this for a few minutes, and then ultimately when you leave the clinic, it's your decision what to do with the information that we discuss. You can also do it just in terms of asking permission. I'd really like to talk to you about this. Is it okay if we spend a couple of minutes on this before we discuss these other things? So any other ways of considering options with patients that you guys have used? Has anyone used the bubble diagram with success? Some people put words in them instead of pictures, or use a verbal menu of options to do some brainstorming, or any other strategies. Okay. So once we have done that exploration of what are the appropriate topics we might talk about, then we have to figure out, okay, what are we actually going to talk about? And that's what zooming in is all about. So motivational interviewing is very pragmatic, and one of the ways we can see that is in this quote from MI3. It's no use setting off for a clear destination if the patient won't go with you. So if you are looking at two different maps, and you have one journey mapped out and the patient has another journey mapped out in terms of what their priorities are, and you are not really paying that much attention to their priorities, and you go chugging off on your trek towards the destination that you have in mind, and you leave the patient behind, then there's not much value to that, really, to anyone. So it's a good thing to consider. So how are we using the time that we have? Are we getting anywhere? Are we getting traction? So once we have done this process of finding out what matters to the patient, clarifying and communicating about what matters to us as a professional, then we can agree how are we going to spend our time together and either find one thing that is clearly a priority for both parties or figure out how to address the priorities of both parties within the amount of time available. Okay, so here is an example of what this could sound like. Before we get started, let's take a few minutes and consider what's important to focus on. I have a list of things in my head that you raised as concerns, and you could also say that I need to check in with you about during our visit today, if it's not in response to the patient concerns. And I want to let you know what's on that list or check in with you about that list. I have some thoughts about what some of the priorities might be. And then there's this example of how you can ask about doing your screening questions now or later, and then asking permission and using hypothetical language to wrap it up. So can we review the list of options, see if there's anything that you want to add, and then talk about where you think we might start. So again, that hypothetical language to share control. Okay, so can anybody talk a little bit about their experience of setting an agenda with patients? Has anybody been using these agenda setting skills and have any success stories or run into any challenges? Okay, well, I'm going to keep moving, and we're going to get to another point of discussion in a couple of slides, and I hope that some people will chime in at that point, because I really think it's super helpful for you guys to be able to share your experiences and to hear from each other. So once you've set an agenda, then, as I said, we want to be consulting our map as we go along. So this is what Larry Mapps, who's a really great teacher of agenda setting, talks about as topic tracking. So this is about consulting your map, using these micro skills to make sure that you're on track with things as you go along. So providing summaries, using process transparency, so describing what's happening as it's happening, and then also, you've zoomed in on something, but you can always zoom out again and make sure that you are still on the same page as the patient in terms of discussing a priority topic. So this is an example of what this might sound like. So Ms. Freeman, we decided to talk about diabetes, and it sounds like juggling exercise and diet is hard. So that's a summary of kind of where we started, what our agenda plan was. I see that you also want to talk about your back pain. So this is process transparency, saying something new is coming up. I want to make sure that we accomplish something concrete today. So explaining, again, this is kind of a process transparency thing. So explaining why you are taking time to set the agenda, why you are zooming out. So then this is then going on to zoom out and say, should we stay with your diabetes or shift our focus to back pain and delay dealing with your diabetes? So sharing control and making sure we are going on the same hike as the patient. So we're using the same map and moving together with our partner. Okay, so we have about 20 minutes, and what I'd like to do is to talk about these three scenarios and what focusing might look like in each of these three scenarios. So, clear direction. I know where we're going, the focus is clear. Let's first talk about if the direction is clear and it's coming from the patient, what would we do? Clear focus, coming from the patient, it's something that we're, that's appropriate for us to be talking about with them in terms of our role. What do we do?
Hi, this is Molly from Whitebird.
Hello.
Hi. So there's coming from the patient. I think following the patient would make sense.
Yeah. So we would say, okay, we have a clear focus. So then we move on, right? So if we go back to think about our four processes and we have a clear focus, then what would we move to?
Would that be engagement?
So engaging is where we started, and of course we want to keep that going the whole time. So we have engaging all along, running throughout our whole interaction. And then we have focusing, so which is what we've been talking about today. So we have a clear focus coming from the patient, and we feel like that's appropriate. We're going to talk about it. Then what happens?
It seems like then it's, if you know where you're going, then it's about the plan, like literally laying it out and kind of like the final step.
Okay, so I think there's something being skipped though. So if we look at this 4 processes, if we go from what we usually do, and this is what makes motivational interviewing distinct and powerful, is that what we usually do is we go from focusing to planning. And if you think back to that idea of motivation mountain, where we have the stages of change running along the bottom, and we have climbing up the slippery slope of ambivalence, and then climbing down the mountain towards planning, which is more in like the action maintenance side of the stages of change. And we see that many, many, many people are actually on the pre-contemplation, contemplation, preparation side of the mountain, which is climbing up the mountain. That's a hard climb. And if we start with planning, then we've gotten ahead of people. So once we have a clear focus, that's when we want to move to evoking, to find out what made you want to talk about this today. Why does this feel like a priority to you? How would it benefit you to make the change? And so this is where we have the opportunity to evoke motivation, to go back to this idea of trying to go from having a bed of cold coals to having some sparks, way to eventually have a glowing, fiery sense of motivation. And then we move to planning. Okay, so how about if we are in that same situation of, I know where we're going, the focus is clear in terms of like, I as a professional have a very specific agenda that I have to address with this patient. How can we go about, in an am I adherent way, managing that process?
You would discuss what you might think is important, but ask them for what they might want to talk about today or what their focus would be.
Yeah, absolutely. So we share control by saying, this is what I need to talk about today, and I'm curious what you want to talk about. How else might we go even a step further to make it more am I adherent?
Hi, this is Christiana from Whitebird. So we talk to a lot of people about, for instance, diabetes. So one way to do it would be like, hey, so I know that you're here today to talk about diabetes, but there's a lot of different things you talk about within it, you know. So and then break down like subcategories and what are your priorities.
Great. And I think that that to me sounds even more like choices and direction, where you have like this big, because diabetes is such a big topic, as you say, like you have to kind of break it down. And that is like, there are several options and we need to decide. So what you're offering people is a menu of options. You're creating structure and guidance by saying, these are the things that should be on the menu. What of those things would be good for us to talk about, which I think is great. So the thing that I was thinking about in terms of, if you have a clear direction that you as a professional need to pursue, and you want to be very am I adherent about doing that, you can ask permission to say, my biggest priority in terms of what I need to get done today is to talk with you about your hypertension medication. Is it okay if we do that? And that way you are sharing control and demonstrating respect, being patient-centered. Okay, so we already heard one way that we could approach. There are the choices and direction. There are several options and we need to decide. So one is by giving options to the patient and asking them what their priorities of those things would be. What else? What other ways do you guys go about if there's a few options and we need to decide between them? So one thing that's coming to mind is I've heard some stories about clinics who use, I cannot remember what clinic actually that was telling this story, but using little whiteboards and having the patient write on the whiteboard what the priorities for this visit were. And so that's a way for the patient to kind of create a menu of options or a list of priorities to say this is what matters to me today. And then we can work together to determine what we're gonna be able to cover. So does anybody have any ideas about how you might frame this to a patient, or how you would talk about it in terms of how you would go from having a set of options to having a clear focus?
Find out what's most important to them within the time limit that you guys have.
Yeah, so that's one way you could do it, is to say, we have this amount of time, what is your top priority? And then what if you what if you as a healthcare professional saw one thing that really seemed more important from a medical standpoint? How might you contribute that to the focus?
You might ask them if it's okay if that's one thing that you talk about, because it seems important to the other areas.
Yeah, so you can ask permission to say, can we make this one a priority? And so if you wanted to share some information with a patient about why you were saying that, so to be transparent, to say, I think this should be a priority, and you wanted to explain why, what would be an am I adherent way to do that?
Asking them permission first?
Yeah, so you could ask permission, like, is it okay? Is it okay if we talk about this, and is it okay if I tell you why I want to talk about it? Another way to do it would be to ask them what they already know. So to say, this one really stands out to me as clinically important. So you could say, like, you're the expert on your life, and so that's why I really wanted to have a conversation that feels relevant to you. From a clinical standpoint, what I see as important is this thing. What do you know about that topic? And find out a little bit about what they know, and then you can share a little bit of information and maybe do a little bit of education around why you think it's a priority. And then using that explore, offer, explore approach, then ask the patient, what do they think? So based on the information I've shared with you today, how does that affect your thinking about your priorities? So it's a dialogue where we're kind of going back and forth, trying to use our different skills to create a focus that is meaningful to both the client and to the professional who is trying to provide guidance around what is the most clinically important topic. Any other thoughts or questions about that, the choices and direction notion? Okay, so how about unclear direction? And to be honest, I'm not sure how much that happens in primary care, where it's unclear what the focus ought to be. And I'm curious whether anybody has an example of a patient or a scenario in which you find yourself where it's not clear what the focus is.
In visiting health, I frequently have that issue. I'll get a referral, but it doesn't say, it just says evaluate and treat. And sometimes the focus isn't clear of what their needs might be or what the doctor was interested in. So figuring out what to focus on.
Yeah. So how do you go about doing
that? Kind of let them know what I do in my role, and then ask if we can talk about certain areas to try and figure out what the focus should be, like, talk about their finances, talk about their mental health needs, and usually a focus will tend to come up.
Okay, so it sounds to me like you're kind of combining engaging and focusing. And I think that that is a really good strategy because in a time when you have unclear direction, I think, as you said, if you can really engage with someone, you can make it clear what your role is, which is part of engaging, and being transparent, and then you can spend some time talking with them in the service of both engaging and exploring what's going on for them, then often a focus emerges pretty naturally.
Correct.
Where something comes through as being more important to the patient, or a red flag to you as a professional, like, oh, this is probably something we should talk about.
Right, like, oh, you can't afford your medications, or something like that.
Yeah. Yeah, and I think it also can be the case where maybe sometimes the focus is unclear if there's someone with a really complex situation. And in those instances, I think engaging is also super important, and sometimes it can create longer to, or it can take longer to create trust and to have a really strong or relational foundation. And again, that's a situation where really investing in engaging and kind of seeing engaging and focusing as kind of interacting with each other as you move through the beginning of the relationship is probably also really useful. Anybody else have any comments about experiences where the focus has been unclear and what you've done to explore that with the patient, or if you maybe have struggled with it and want some consult from your colleagues here? You guys are not at your chattiest today, I gotta say. It'll really be more interesting if we're having a conversation instead of me talking at you. So if I can coax anyone into sharing a story of any kind about focusing or agenda setting, I think that would be a great way to spend our last few minutes together. So this could also be about focusing in the context of time management, focusing in the context of addressing specific conditions. If you feel like, man, focusing is actually not really relevant to my work, we could talk about that too.
Hi, this is Christiana from Whitebird. I have a story about, I know some people are sometimes given unclear referrals. I had a situation in which I was going into a conversation with wrong information, and already had an agenda in my head based on wrong information. And it took me what it was is I was calling someone back about a test result, and it turns out that they actually had gotten the test result back. And so I was trying to get them to do this thing they had already done. And I guess all I want to say is listening, not only when the client is saying what's important to them, but also listening to what the client when they're responding to you. Anyway, I was so focused on what I thought that I didn't actually catch that I was walking into the situation.
And so how did it become clear that you were barking up the wrong tree?
Well, luckily, although I didn't catch that, I was still using reflection, and so he corrected me on a reflection. It was like,
oh, great.
So the next step is this? No, I've already done that step. The next step is this.
Yeah, that's terrific. I think that's a great example of the usefulness of being wrong and using reflection, where the person had the opportunity and took the opportunity to correct you, and because you were listening to his responses, you were able to get back on track. So how did you, once you clarified that, how did you reestablish the focus and create a more appropriate focus given the fact that you'd already done the test?
Well, maybe it wasn't a great example in the sense that, he didn't need motivational interviewing at that point because the ball was actually in our court. We needed to do something for him, so we just put up a plan of follow-up. It kind of made the conversation unnecessary.
Yeah. So that's an example, actually, to go back to someone's earlier comment where I said we shouldn't just go from focusing to planning. This is an example where actually that's exactly what was appropriate to do, where you didn't need to do evoking, where you recognized, okay, motivational interviewing isn't really what's needed here. We just need to figure out this guy is working on his health thing, whatever it was, and we just need to figure out what the next steps are.
Yeah, so I guess my point was really that I was so focused on, like, okay, these are the steps of motivational interviewing that I want to go through. And that's not, you shouldn't be too zeroed in on that.
Right. Yeah. Yeah, and I think, Miller and Rolnick would say that the best teacher is going to be your patients or your clients. And so I think that's a great example of, like, you had your mind set on what was going to happen, and then you ended up redirecting on the basis of the feedback you got, and that would be a very appropriate way to use your MI skills to stay on track. And it may be also with that particular patient that you have some rapport and a relationship, and in the future there might be an opportunity to have another conversation with him where you can build on that foundational rapport to say, okay, you've done this test, these are the results. Let's talk about either what that means for you or what other health priorities you might have. And there may be another topic around which he does need some evocation and exploration of ambivalence, and you have this engagement established with him and can use your MI skills to provide better service over time.
Yeah.
Awesome. We have a couple minutes left. Any other comments about focusing? Okay, well, we'll go ahead and wrap things up. I'll send the slides to Diane. Thanks to everyone who participated today. And we'll be getting together again next month. I'm just going to go back to that list of dates so I can tell you. July 9th to talk about reflective listening and to do some reflective listening practice. So I hope you have a great month, and I will talk to you then. Take care.